Hello, everyone. I'd like to welcome you all and thank you for joining me here in this webinar about indirect pulp treatment, why material matters. My name is Atmeh. I am Associate Professor and Consultant Endodontist in Mohammed bin Rashid University of Medicine and Health Sciences in Dubai, United Arab Emirates. I'm also a visiting lecturer in University of Birmingham. Just to give you about my background, I graduated, I got my bachelor degree in dental surgery from Jordan University of Science and Technology in 2004. And I got my master's in endodontics from the same university in 2007. Then I moved to the UK, King's College London. I had my PhD and part of my clinical training in endodontics and finished that in 2013. After that, I have worked in different universities in the UK, Jordan, Saudi Arabia, and the UAE. So it might be a bit awkward or surprising for you to be listening about indirect pulp treatment from an endodontist. But to be honest, there are two reasons for me to talk to you about this. First is that my PhD was actually about calcium silicate cements, and I spent a lot of time studying this material in the research lab. In fact, I was among the few people who studied Biodentine just when it was first launched in 2010, which gave me a great insight about the capability of these materials as restorative materials. The second reason, to be honest, is being an endodontist doesn't just limit our interest in the root canal space, but also we care about what fills the tissue that fills that space, that's the pulp. And since eventually or ultimately we aim to protect the periapical tissues, this protection starts from the preservation of the sound dentine and sound dental tissues and sound pulp. So preserving the pulp is the first step of preventing any periapical disease. So just to give you an idea about the topics that we will be covering today and the outline, the structure of this webinar, we'll talk lightly about the caries management and indirect pulp treatment, and then talk about the materials in indirect pulp treatment and why it matters. And that's actually the main purpose of this webinar. We'll touch on some clinical applications, when to consider indirect pulp treatment, and the concept of biobulk fill procedure, and then we'll finish with conclusions and take-home messages. So let's start with the problem, the dental caries. Now, according to the WHO, and we all know that dental caries is the most common non-communicable disease, meaning that it's on the level of humanity. That's a major problem. Maybe every single one of us have had a cavity in their teeth. Now, the scope of this, because of the scope of this problem affecting a large population, the other aspect of this problem is that it affects dentition, which cannot be replaced. So the tooth structure that is lost, then it's not going to be repaired like any other part of the body, like bone, for instance. So any lost structure means that it will be associated with lost function and lost aesthetics. Now, the other problem with caries is that it is progressive. So it starts with, as you know, it happens due to the acidic production from acidogenic or carcinogenic bacteria that lives in our mouth, and due to the dietary habits that we have, this bacteria will start producing the acids. Now, those acids will attack the enamel surface, and then with time it will reach dentine. Then the lesion will start to cavitate, allowing more bacteria to invade. So with time, the cavity or the caries lesion is actually going deeper into the dental tissues. And we know that the structure of the tooth was made as a hard outer shell that will protect the delicate inner pulp. That's the vital part of the tooth. So with the time, as the lesion is actually progressing closer to the pulp, it's invading the intact protection that was designed to preserve and protect the tooth. So progressive loss of the outer protective hard dental tissue means there is a higher risk for the pulp starting from early caries, then deep caries, and advancing towards extremely deep caries until it reaches to the pulp space. The other level, with this progress in the loss of the hard tissues, then there is an effect on the pulpal tissues inside. And that's where you can see that with the deeper lesions, the pulp will start affected with inflammation. Now, although these are clinical descriptions for what happens inside the pulp, it's not histological, but somehow it describes the changes that affect the pulp. So we start going through pulpitis and then end with necrosis. So this is the second line or progression of the dental caries. Now the third level is actually the periapical tissues, and we know that by the time the pulp is affected, and in which it cannot withstand any further irritation from the caries invasion and bacterial invasion, it will go into necrosis. And once the tissue and pulp is necrotic, then the bacteria will invade that space and will have its way to invade the periapical tissues. And that's how it appears as a periapical lesion radiographically, or a periapical abscess, and so on. So these are the three levels that shows how caries is progressing. It progresses on the level of the hard tissues, level of the pulp, and level of the periapical tissues. Now, how we can relate this information to the way we manage caries? We know that we have all learned that we manage caries or treat caries lesions because we want to restore the function. We want to replace those ugly black holes in teeth with more nicer restorations. So the appearance, the function, the structure, these are the most reasons that we think of when it comes to managing caries and restoring teeth. But there's another aspect, very important aspects that should be taken into consideration when it comes to caries management. And that's what I call the three Ps. Starting from keeping in mind that we need to preserve the structure of the tooth while we're treating the cavity, balancing between what we remove and what we leave behind. Secondly, to protect, keeping in mind that we want to protect the pulp, because the pulp, as I said, is the vital part of the tooth. And preserving that tissue will definitely impact the viability of the tooth, because the moment we start a pulpectomy and a root canal treatment, then we're actually increasing the risk of losing that tooth over a shorter period of time. And ultimately, at the end, we should aim to prevent periapical disease. And that's what matters importantly, because this is the disease we are actually, or the problem that we want to avoid. Because once the periapical tissues are affected, that's going to be, again, a progressive effect that may lead to the loss of most valuable tissue, that is the bone, and that will limit the patient's options in the future to have any, for instance, implant. So keeping this in mind and thinking about the caries management, not just about a simple restoration that we put in place, it's more than that. It's preserving structure, protecting the pulp, and preventing periapical disease in the future. So if you want to define the indirect pulp treatment, there are different definitions by different societies and institutes. But I found that this definition by the American Dental Association is the most representative. So as description, it's a procedure in which the nearly exposed pulp is covered with protective dressing to protect the pulp from additional injury to promote healing and repair. So there are keywords here. So nearly exposed, meaning that the pulp is not exposed, and that's the obvious reason why we choose to name it indirect pulp treatment, which is different than or opposite to the direct pulp treatment, in which the protective material or the pulp capping material is placed directly on the pulp. And the other word is to protect the pulp, and that's what we will be seeing over the next slides, how the indirect pulp treatment should work and function to protect the pulp. So how can we protect the pulp? If indirect pulp treatment is meant to do so, what is the factors that would affect that? In fact, there are two factors that relates caries management with providing the protection to the pulp. The first is what is the stage that we are intervening, and the second is how we intervene to manage the caries. So I know that when it comes to caries management, it's not up to us to decide when we should intervene. Most of the time, actually all the time, the patient is the one who comes to the clinic seeking the help. So if the patient is coming at early stage, it's different than a patient coming in very late stage with badly huge carious lesion that require invasive intervention, such as root canal treatment, if not extraction, if the tooth is restorable. So that's why the stage of our intervention define how much protection we can provide to the pulp. So simple caries restoration for a shallow dentine caries barely need any additional measure to protect the pulp, as long as we're conservative in removing the caries dentine. On the contrary, if you go to the other extreme, in which you have more advanced and extremely deep caries, in which it's almost reaching the pulp chamber, that's where you have to consider slightly more invasive approach like pulpotomy, partial or full, or even direct pulp capping. In these cases, the pulp protection is already compromised. You're not able to preserve the dentine shell around the pulp. So you have to consider, you're not considering the most invasive, like the RCT and extraction, but still you have to consider more invasive approach than just a simple restoration. And that's where the indirect pulp treatment actually located. So it's in between the simple restoration and the pulpotomy. So it combines the vital pulp therapy, it combines the therapeutic component of vital pulp therapy, but with preserving the dentine. So you are avoiding the pulpal exposure and avoiding exposing the dentine. The other factor that relates to the way of how we protect the pulp with indirect pulp treatment is how we are actually intervening, and that's related to the our approach in caries removal. And we know that there are different schools when it comes to caries removal. Some may advocate complete, some may advocate selective, which at the end it aims to remove the caries part of dentine. But regardless to the approach, we have always to keep in mind that additional or excessive removal of dentine will come with a price, that we are increasing the chance of pulpal exposure, which means that there is higher chance to irritate the pulp. And that's why we have always to keep the balance. And that's that's why, again, why we are trying to avoid exposing the pulp, why we're so conservative, why we have to take this into consideration. Because losing exposing the pulp might first expose or disturb the natural structure or function of the pulp. So the pulp has the dentine is a physical barrier, and that barrier, if it's lost, then there's a chance of losing the structure of the pulp itself, and that affects the function. The second is you may also lose part of the pulpal tissue with that. So you're actually limiting the capacity and the ability of the pulp to respond and heal, which was already designed to withstand, to some extent, certain level of irritation, and it can recover under proper conditions. And that's why we have to provide these conditions for it to heal. And the third and most important is that with exposing the pulp, you're actually giving access to bacteria and contamination. So you're increasing the chance of contamination, and bacterial contamination is the main reason for failure of any kind of treatment. If we talk about vital pulp therapy, if we talk about root canal treatment, even any kind of medical procedure, contamination, bacterial contamination is the worst scenario that you can encounter. So that's the reason, the three reasons why we want to to avoid the pulpal exposure. And that's why we always should aim to be as conservative as much as possible to avoid excessive or unnecessary, I would say, removal of dentine. So with minimally invasive approaches in dentistry, that would provide preserving dentine, and by that you're actually protecting the pulp. So this is how we relate the way you are intervening in your caries management with providing or achieving a successful indirect pulp treatment meant to protect the pulp. So to sum up, the rationale of indirect pulp treatment is preserving the natural structure as we described. We want to preserve the pulp-dentine complex because it has to work normally. What also we aim to lower the risk of bacterial contamination, and with that we want to preserve or provide an intact dentine that can induce healing. And we know that dentine by itself plays a very important role in the healing process of the pulp, one of which is the release of growth factors embedded in dentine. So you are, by preserving dentine, you're involving dentine in the healing process of the pulp. But saying that, we should always keep in mind what's the clinical picture of that lesion. I mean, the indirect pulp treatment is definitely not suitable for every single case. You have to be selective about these cases. So which case you might consider it as suitable for indirect pulp treatment? How would you choose that this case is actually appropriate? Well, like any other treatment, that starts with proper and thorough pain history and symptoms from the patient. So to start with, the patient is not supposed to have severe symptoms, because severe symptoms is an indicative of advanced stage of pulpal involvement, which require either a pulpotomy if vital pulp therapy would be considered, or even root canal treatment. So symptoms-wise, we're not talking about severe symptoms. And even the pain history should not be indicative of irreversible pulpitis. So we are talking about mostly reversible pulpitis. Sometimes we may consider irreversible if we think it is suitable. So it's a balance between the advantages or pros and cons of what we provide. Secondly is the clinical assessment. You have to run or perform your pulp tests, whether you're doing a cold test or electric pulp test. You have to assess the pulp sensibility, because the last thing you want to do is to proceed with a indirect pulp treatment or even vital pulp therapy while the pulp is dead. So also you have to assess the tooth, whether there's any tenderness to percussion or pain on palpation, which are indicative of periapical involvement of the tissues. And lastly is the radiographic examination, in which it gives you an idea about the depth of involvement or the depth of the carious lesion and its proximity to the pulp tissue. Now, the issue here is we are always limited when it comes to the tools that we have. So listening to the patients complain and even the tests that we do are totally subjective. It depends on what the patient will tell us. And that's why we cannot be 100% sure that the diagnosis we're relying on to provide the treatment is accurate. And that's something we should keep it in mind. And maybe that's why whenever we provide the treatment, we have to think about alternative options if that treatment didn't work, maybe because the diagnosis was not accurate due to the reasons I have just mentioned. But anyway, the more careful you collect information from the patient about their complaint, about the pain, about the clinical assessment combined with radiographic examination, then that is what helps you to identify the problem and provide the best treatment option. And this is just to show how would you consider treatment based on the radiographic appearance. And again, radiographic appearance by its own solely is not supposed to be your only way to assess your treatment plan or even diagnosis. So you should combine it with the other findings. But according to the European Society of Endodontics, they differentiate between two levels of caries. The deep caries lesions, in which the caries is reaching the pulpal quarter of dentine, and it can be detected radiographically, which appears as an intact or well-defined radio-opaque zone, just above the pulp space here between the lesion and the pulp space. So in these cases, you may anticipate that you might end up with sound or intact dentine, and you will not end up with pulp exposure. The extremely deep caries, on the contrary, based on the definition, the caries is actually penetrating the entire dentine, and it's reaching the radiographic reads, reaching the pulp space. So pulp exposure in these cases is anticipated, and it is unavoidable during operative treatment. And for those cases, most probably will end up with, as I said, either pulpotomy or pulpectomy, depending on the clinical picture of this treatment. So, for an optimal indirect pulp treatment, you should start with a proper examination and diagnosis, proper history, proper assessment of the pulp response for different stimuli. I wouldn't rely on one test. I would consider thermal and electric, because sometimes, again, as I said, it is subjective. Patient might not be accurate in their response. We have always, as we described, to minimize dentine excavation as much as possible, because that's one of the factors that would help protecting the pulp and reduce its involvement. And obviously, you have to work under isolation to minimize the chance of contamination. Specifically, if we are expecting pulp exposure, then that will play a major role in the treatment. Operate under magnification, and that's again very essential, because sometimes the pulp exposures are very tiny. You might not be able to detect with your naked eye, and that's where the magnification plays an important role. Even it helps with the way you manipulate the materials and apply or manage the caries and so on. So it gives you or puts you in a different level than what you if you're practicing without magnification. And lastly is actually the material, and that's what will move us to the second stage of our discussion in this webinar. So the question is, does the material matter? I mean, we talked about the caries management, we talked about the stage of intervention, we talked about the way we intervene to manage caries. So the last step is we have to place the material as an indirect pulp treatment. We may think, okay, I think we already protected the pulp. Why do we have to consider the material? Now, that's why I need to bring back the definition again. And here I will highlight two words in the definition of the indirect pulp treatment. So it's as we said, it's meant to protect the pulp from additional injury and promote healing. So these are these two functions. So promote healing, then this definitely cannot be achieved by the way we excavate or remove caries. This has to be something we are introducing to the cavity or introducing to our treatment to promote healing. So how does this relate to the material selection? And let's look at this paragraph that was actually listed or mentioned in the ESE guidelines in 2019. They stated that the lack of permanent coronal seal during the less invasive caries removal strategies will lead to failure, including pulpal and apical pathosis. So this is just to say that the seal, as simple as seal, the ability of your temporary material to provide seal, will play a very critical role in the success of your treatment. So you might be doing everything perfect, preserving the dentine, preserving the pulp, but you placed your selection of the filling material was not, or the pulp capping material was not optimal. that would be one reason for the failure to happen. And again, as I said, the indirect pulp treatment is a combination of preserving, as we discussed before, but also it's complemented with protection. And the protection is actually coming from the materials. So the materials that we have actually, especially with the introduction of calcium silicate cements, they introduced a new level of properties, or provided played a new role that shifted from just providing the seal to other level of other combination of effects. And that's here we can combine both the dentine preservation and pulp protection with the pulp capping material. And you can see that with excessive dentine removal, you increase the chance of pulp exposure. Now, if this is combined with a poor seal, then that's a hard chance for the treatment to fail and will require either more invasive treatment or might end up even with root canal treatment. However, if the same treatment, even with excessive dentine removal, but you applied a proper material, then that will shift the outcome into more favorable outcome, meaning that you're actually enhancing the chances of your treatment to be successful. And that's why the material that you're using plays a very important role. If you're using a more conservative approach in dentine removal and you're preserving the dentine, then definitely you need to complement this with a proper protective material. That this combination was actually in favor of, allows you to take advantage of the vital pulp therapy and get the best outcome out of these. So this is just to show you how what are the different interventions that we usually considered like indirect, direct, and the more we shift into the right side, then these are the more invasive treatments. The more the invasive is the treatment. So again, it's the function of these pulp capping materials now is more than just provide a seal. It can play more roles than it used to play as a seal. So you have, beside the seal and protection, you have the capability of these materials to induce remineralization, which is much wanted if you're actually removing dentine selectively and you want to consider you want the caries affected dentine, encourage remineralization of that of these tissues. It's also provide therapeutic effect to the pulp, and that's the most important part, because again, as I said, what you do is you're providing the best conditions for the pulp to heal and repair, and those conditions could also come with additional influence of the material to the pulp. And thirdly, you have the antimicrobial properties, which can also complement the three other properties, because by reducing the chance of infection, you're giving the pulp the proper chance for it to heal. So these four properties, they are they exist, or you can find materials with different combinations of these properties and with different extents. So one material might combine the seal and the therapeutic effect, but it doesn't have the remineralization potential or the antimicrobial effect, and so on. So ideally for us, the best material that we need to seek is the one that combine these four together in one material. And again, back to the ESE guidelines for caries, for the management of deep caries. Their recommendation was to, and I would read it here, as dentine thickness of the pulp cannot be accurately assessed clinically, the use of biologically based material is recommended, such as hydraulic calcium silicates. And now, the context here is that they're saying that because sometimes you're not able to distinguish if you're placing the material as direct and indirect, those materials, you need this kind of materials. But the role is actually more than that, and that's how I will explain to you in the coming slides. Now, if we think about the materials that has been historically used for indirect pulp treatment, the most common one is calcium hydroxide. Then we have the resin-modified glass ionomer, we have the resin-modified calcium silicates, you have the glass ionomer cement, and the hydraulic calcium silicate. Now, calcium hydroxide has been the most common, and whether in the era where amalgams used to be applied, and even currently with composites. But calcium hydroxides are not optimal. As I said, the combination of these four properties on the right, they differ from materials. So in terms of sealing, calcium hydroxide is applied as a liner, and those may not provide the best seal, and the seal is mostly dependent on the definitive restoration on top of that liner. Beside that, because of their nature, they are soluble over time, so they dissolve over time, which also add additional risk for poor seal. Antimicrobial properties are not considered the best, so they lack this property. And eventually, even with the quality of or the conditions they provide, it has been shown that histologically the pulps that were on which calcium hydroxide was used, the integrity of the dentine bridge was not great, was associated with multiple tunnel defects. So this just to show how the classical approach in indirect pulp treatment or capping using calcium hydroxide is not optimal. What about the resin-modified glass ionomer cements and the resin-modified glass silicates, calcium silicates, I'm sorry. So both they have in common, they have resin in common. And resin, although it comes with really clinically friendly properties, and the most important is that you can it can set instantly. Just shine the light cure on it, and it will set harden instantly. This is much very convenient for us inside the clinics because we need things to happen quickly. But that comes with a price because they include polymers, and those polymers, firstly, they could be toxic, especially if they didn't polymerize, if it didn't go into a full reaction. So what is left as free monomers will permeate into the pulp and affect the pulp. So instead of protecting the pulp, providing the best conditions for it to heal and respond to our indirect pulp treatment, we're actually imposing additional risk for it and imposing further irritation. So to me, anything that contains resin is not the best to be used direct or indirect to the pulp. What are we left with is glass ionomer and hydraulic calcium silicates, and those actually are the materials that are most currently mostly recommended for indirect pulp treatment. But the question is, how do they compare? I mean, do they perform the same when it comes to indirect pulp treatment? Does it make any difference if I'm using glass ionomer versus hydraulic calcium silicates? Well, let's understand or try to understand the differences between these materials. Now, in principle, glass ionomer cements and hydraulic calcium silicates are two opposite in terms of nature. So hydraulic silicates, calcium silicates are alkaline. Their pH is around 11. And anything alkaline is like more into remineralization and more into biological changes or favorable biological changes, while the acidic, especially on mineralized tissues, this means loss of these tissues. The pH of the glass ionomer is around 2 to 4. So these two different natures comes from the way these materials actually, or the chemistry of these materials. So the alkalinity of the hydraulic calcium silicates comes from the production of calcium hydroxide. So once the particle of these cements are mixed with water, we call it hydration reaction, it will produce calcium silicate hydrate and calcium hydroxide. So the calcium hydroxide is the source of the high pH. While for the glass ionomer, the acidity comes from the reactants because it is based on mixing a polyacid liquid with the particles. So mixing this mixture will be acidic due to the presence of the acid in the reactants. Now, what does it mean for pulp capping material? Does it really matter if I'm using an acidic material or an alkaline material when I place it on dentine as an indirect pulp treatment? Well, this it means that different interactions, because of their different natures, they will have different interaction with the surrounding environment. And I will explain it here. As I've just mentioned, the setting reaction of hydraulic calcium silicates starts with mixing with water. So once they are mixed, and that's why they are called hydraulic, once they are mixed, they will produce the calcium silicate hydrate and the calcium hydroxide. If we think about the calcium silicate hydrate, that's the part that gives the mechanical and physical properties for the cement. So it hardens, it gives the strength, and so on. While the calcium hydroxide is actually produced as a porous solution within the cement. So you can imagine it as a sponge filled with water. This water is rich with calcium hydroxide. And that's why the calcium hydroxide mediates the therapeutic and biological properties, mainly due to the hydroxyl ion and beside the calcium, which can function as or included in many biological pathways that happens during healing. So this ion-rich porous solution, as explained, contains the calcium ion and the high pH. Now keep the in mind, or the image of the sponge with filled with water, and imagine that this is placed on dentine. And here you can see this is an image taken for dentine at the bottom, and we have a calcium silicate cement placed on the top. And this calcium silicate was actually mixed with a green dye. And you can see that when we place the cement on dentine, there was a layer that fall within dentine. So this layer is not part of the cement. This layer is actually within the dentine. This means that there is kind of interaction between the material on top of the calcium silicates and the dentine. And this include the fluid transfer mediated by the porous solution. So the ion-rich solution produced by the cement, it will leach out to be transferred into the dentine. Now, what kind of interaction happens there? Let's compare it with glass ionomer cement. Now, you have both the glass ionomer on your right and the calcium silicates on the left. And due to their different natures, they will react differently, as we said. So here, the high pH alkaline, it will target the organic component of dentine, that's the collagen, and that's what allow the fluid to permeate deeper. So it affects the collagen, it increases permeability of the fluids, and it goes into the dentine. While the opposite happens in the glass ionomer. Because of its acidity, it will not target the organic, it will target the inorganic, causing demineralization of the interfacial layer of dentine. And that's what causes the fluid to permeate. So both cements, they are interactive. Both they create interfacial layers, but the nature of these layers are different. One is alkaline, which could be favorable for and encouraging for remineralization, because remineralization usually occurs at high pH, while the other one that is acidic could, on the contrary, cause further damage to the dentine and counter, despite the good mineralizing potentials of glass ionomer, but still it has a demineralizing effect on dentine. And further, it can also negatively affect the pulp because the low pH is irritative to the pulp as well. So if we, just to give you further explanation what happens to the hydraulic calcium silicates when placed on top of dentine. As I said, once it is placed, it will produce calcium hydroxide. Calcium hydroxide will diffuse as intertubular diffusion, so not through the tubules, it's just between the tubules. Now this will result in mineral transfer and alkaline etching to this zone here, and that's why we call it the mineral infiltration zone. Now, why does it matter? Why we're talking about this? Because one of the main factors that we started the discussion about was how the material play a role in indirect pulp treatment, and we said that the most essential role is seal. So if we have a material that can interact with dentine in this format, then that's a sign of a proper seal that could be provided by the material. And that's why such materials, because their interactivity with dentine, that mediates their suitable as at basic level to provide a proper seal and prevent any leakage, which give the, again, the as I said, the basic conditions for the pulp to heal. Now, the diffusion may not just happen through the intertubular diffusion. We also have diffusion that happens through the tubules. So you can see here that through the tubules, the pore rich solution, rich with calcium hydroxide, it will permeate through the tubules and reach the pulp. And that's why how these materials can still act indirectly. We know that when we place calcium silicates, indirect contact with the pulp, they are very bioactive. They will induce a positive reaction for pulp healing. But even if they're not placed in direct contact, like here, they would still impose the same effect. And that's why they have a pulpotherapeutic effect. Now, beside that, because of the high pH, it will also encourage the release of dentine matrix proteins, which plays a very important role in healing. So although you're placing your material indirectly, but still it has a impose a therapeutic effect to the pulp. And just to list these effects, first, the calcium silicates, they produce calcium hydroxide over longer duration. So unlike calcium hydroxide liners, the calcium silicates will produce lower concentration of calcium hydroxide, but over longer duration. So that will maintain longer effects, which is advantageous for the pulp healing and antimicrobial properties. It's also, it's not imposing any further irritation, unlike the acid associated with the glass enamel. Glass enamel is acidic, so that comes with more irritation to the pulp. Thirdly, it releases dentine matrix proteins, which encourage or plays a very essential role in the tertiary dentine formation and response. And lastly is the high pH, which can exert an antimicrobial properties, which you don't see with glass enamel. Those antimicrobial properties are much needed beside the proper seal and the release of matrix proteins, because it all complement each other for proper conditions for the pulp to heal. And thirdly, so we talked about the seal, we talked about the therapeutic effect, but also we have a remineralizing effect of calcium silicate cements. And here you can see that these are totally demineralized dentine that was subjected to calcium silicate cements. So it was calcium silicates, they were stored in the presence of calcium silicates. And you can see here signs of mineral formation within these demineralized dentine, and you can see the difference here. This is demineralized, and this is mineralized by the calcium silicate. When we compared it with glass enamel, which is famous for its ability to remineralize, it was comparable when the dentine was not fully demineralized. But when we used a fully demineralized dentine that could be similar to caries infected, it played much better performance than the glass enamel. So in other words, the calcium silicates and biodentine, they have a much better and wider capability to induce dentine remineralization, which again is much needed in cases where you are performing selective caries removal, and you count on the material to encourage remineralization and repair of the firm dentine that was left behind. So in conclusion, glass enamel and calcium silicates, they're not the same. They have different natures, they have different capacities and different suitability for indirect pulp treatment. And at the end, it's more biologically compatible to use to benefit from these the properties of calcium silicates and avoid the disadvantages coming with glass enamel as pulp capping material. Now, the second question is, Are all hydraulic calcium silicates the same? I mean, they're all the same family, they're all hydraulic calcium silicates, but if we compare these materials, do they perform the same? Do they give you the same properties and efficiency? The answer is no. And simply because these materials, although they are the same family, but they have variations, they have different formulations and compositions. And that means they have different properties. Now, the thing about biodentine is it's the clinical scope of application, that it's meant to be a therapeutic material like any other calcium silicate or any other pulp capping material. But beside that, it is meant to be a dentine replacement material. And that's because of the unique properties of this material. Now, this comes from the composition and formulation. If we compare different materials like MTA, biodentine, or even total fill, which is a different category of material that that are applied injectable materials. Now, those we have two types of in terms of composition. One type is based on Portland cement, and that is the MTA, while the other, like biodentine, is based on pure composition, in which it is produced in the lab. It's not produced in a factory like the Portland cement. So this give more control on the constituents of these materials, and even more control on their purities, which also the additives between these materials can vary. So if you look at MTA, it contains calcium sulfate, for instance, while biodentine, it contains calcium carbonate. Other materials have different composition. So the bottom line, all these materials are calcium silicate cements, but they have variations in their composition. Now the question is, how does that affect their performance? One example here is to see how the composition might affect their performance. Biodentine contains calcium chloride in their liquid or solution. So the calcium chloride is actually an accelerator. It accelerates the setting reaction, contrary to the calcium sulfate that is part of the MTA. So the presence of calcium sulfate will counteract the setting reaction and will slow it down. So this is why it's important to understand what are the differences between these materials, the differences in composition and performance. If we talk about the mechanical properties, and this is just to show that comparing the different calcium silicates, biodentine shows a much higher compressive strength compared to the other materials. And that's very close to the strength provided by glass ionomer. And that's why the biodentine is meant to be a restorative material based on the properties and the mechanical strength it gives. And for pulp capping material, such mechanical strength could be needed because you are actually providing a mechanical protection beside the seal and the therapeutic effect. You're providing a mechanical protection for your for the pulp, especially if it is placed as for some time as a temporary material before you place your final restoration on top of it. Again, because of different properties means different composition means different properties. Therapeutic effects, which is much related to the alkalinity and pH, is also different. If we compare the same, if you look at the black bars here, this just represent the pH of these materials after 1 day, which is almost the same across the materials. Now, the red bars, on the contrary, is the pH after 4 weeks, and you can see that the biodentine kept the highest pH even after 4 weeks. Is that advantageous? Yes, because as we said, the high pH means that there is a constant release of calcium hydroxide, which mediates the biological and therapeutic properties of these materials. And the same for calcium release. So you can see how much difference is the amount of calcium released by biodentine compared to the other materials. Again, this all goes back to the difference in the formulation and composition. Now, in summary of this discussion, if we compare the materials like Biodentine with other materials, they are not the same based on the composition and based on the formulation, based on the properties. And that's what justified the use or give the Biodentine the advantage or the unique status as a restorative material, because of these properties that allows it to be used as a coronal restorative material. While with MTA, it's just limited to either you can use it as a liner with vital pulp therapy or other conventional endodontic or surgical applications. So Biodentine is a restorative material suitable for indirect pulp treatment, which is not the case for MTA. Now, what about the clinical performance? Now, different clinical studies have been done to assess the success, and most of these studies recorded a success rate between 90 up to 100%. Now, most of these clinical studies that compared different materials maybe showed comparable results with materials that we conventionally use with pulp capping. But we should always take into consideration that success is not just limited to curing the disease. There are other aspects or other dimensions that should be included to decide about success. And one of the most important is how comprehensive your treatment is. I mean, if you're considering a treatment or considering a material, how much scenarios this material can address. For example, if we, when we talked about the possibility of micro exposures and the possibility of undetected pulp exposure, if you place a material that's meant to be used as indirect pulp capping and you have a pulp exposure, then you are actually not giving the pulp, as we said, the proper chance for it to survive. It will eventually, it might be, it goes into necrosis and further root canal treatment. But if you're considering a material that's suitable for to be placed, whether indirect or direct, then that's a better solution. And that's what a comprehensive solution means. Durability is also very essential, because you want a more predicted outcome. You want more durable solution for your patient, which again, it affects their satisfaction. And most importantly, the cost effectiveness as a clinician, how much adding any material to your clinic will help providing high quality treatment with much less cost. And again, when it comes to cost, it's always good to compare the cost of providing a vital pulp therapy for a patient versus root canal treatment, considering that you are with proper selection of these cases. And that's why you should always ensure that patients receive value for their investment. Patients receive value for what they pay against their treatment, with minimal need for further intervention. So all of these are actually part of judging how material is successful or not. Numbers are good, numbers are indicative, but again, we should also think about other factors when it comes to comparing the clinical performance of these materials. And that's why, again, to relate to the comprehensive solution, Biodentine can provide or can be considered as a comprehensive solution. So if we talk about managing deep caries management and placing it as indirect pulp capping, so Biodentine can act as the pulp, act on the pulp, even, as I said, without direct contact with it. On the contrary, if a pulp exposure happened, then you can place it safely, because it is bioactive. It will induce its most pulp-friendly material, as like calcium silicate material, which will encourage the pulp to heal and give it the chance to survive. So whether it's direct or indirect, it's still acting. Furthermore, if you place it on fuse it with selective caries removal and place it on firm dentine after removing a soft dentine, then this is also will act through its remineralizing potential. So it will encourage the repair or remineralization of caries dentine, and by that you're actually somehow minimizing caries excavation as well. Now, one more application for that is actually under biodentine could be suitable to be placed as dentine replacement under composite restoration. And we know that composite restoration in deep cavities might not be the best in terms of post-operative pain due to the post-polymerization shrinkage that happens, that could pull the composite from the walls and allow some kind of micro leakage and increase stresses on the tooth and the pulp. Placing a dentine replacement material like biodentine that could be pulp friendly, that could provide the seal, could actually avoid this kind of problem and give relief to the patient to consider. And by that, combining all these, this what gives the biodentine a comprehensive solution when it comes to indirect pulp treatment. So if we want to just go through the steps, if you want to select a proper case for indirect pulp treatment, definitely the first step you would start with is judging whether the tooth is restorable or not. And here I'm talking about really deep caries lesions. So restorability is the first line of judgment, because if the tooth is restorable, then definitely it goes for extraction. If not, then you take it for the next level. You have to assess the pulp. What's the status of the pulp? Is it vital? Is it responding to the pulp test or not? If it's negative, no response to cold or electropulp test, this is an indication of pulp necrosis, and definitely this goes to a root canal treatment. But if the pulp is responsive, then you have to look at the symptoms. And again, as mentioned before, symptoms could be an indicative, although not accurate, but the best indicative of the pulp status with the other tests that you do. So having severe symptoms and a positive response to cold test, like severe response to cold test, this is an indicative of a symptomatic irreversible pulpitis, which mostly we would tend to perform a root canal treatment. Now, if there's a response, a positive response, but there's no symptoms, then that means that the pulp is reversible pulpitis, and that's a very suitable case for indirect pulp treatment. So aim to preserve the tooth structure, minimize the excavation, and provide a protective material on top to provide the proper seal and other properties that we discussed. If the symptoms also could be mild or moderate, then indirect pulp treatment could be suitable as long as there's no pulp exposure. Sometimes you might start your excavation and then you will end up with caries exposure. If caries exposure happened, then I would recommend pulpotomy. Never, I wouldn't recommend a direct pulp capping, because caries exposure means that the pulpal tissues are involved, and there's a potential of bacteria present in the tissue, and the tissue are severely inflamed. So it's always better to remove part of the tissue. That's what pulpotomy is, whether it's partial or a full pulpotomy, and perform your treatment. And here you can see that I added an arrow for cases with severe symptoms, because still with recent evidence, there is more inclusion of cases with pulpitis to be treated with vital pulp therapy. So that could be an option at one stage, especially if you have the proper material that could push towards pulp repair and healing. Now, sometimes you may not be able to avoid a traumatic exposure. In these cases, you end up with direct pulp capping. So direct pulp capping is just with traumatic exposure, in which you know that there is no caries exposure, there is no pulpal involvement in these cases. Now, if we want to relate the role of biodentine to this, you can say that all of this is actually can be achieved by the Biodentine, and this is the comprehensiveness of this material. It can be used for pulpotomies, it can be used for direct pulp capping, and it can be used as indirect pulp treatment. So regardless about the certainty of your treatment plan that you start with, at least you know that you will end up, you have a solution for whatever treatment that you will end up with. You don't have to consider different materials. Let's say if you want to end up with pulpotomy, you will consider this material, direct pulp capping, different materials. So you have one material for all these scenarios and options. And that's exactly why Biodentine is a comprehensive solution when it comes to vital pulp treatment. Now, the term of bi-bulk fill came to describe using the Biodentine to fill the entire cavity from the pulp to the tooth surface. And as I said, the Biodentine is unique because it's the only calcium silicate material that can be used as restorative material, as a dentin replacement material. So it came with this approach as a bi-bulk fill. So the idea here is that, unlike the pulp capping material that are applied as just a thin layer of liner, 1 or 2 millimeter, the Biodentine can be placed to replace the whole thickness of dentine, and then covered with a definitive restoration, whether we're talking about composite or we're talking about indirect restoration. And just to show how this is done, this is a caries excavation was performed on that tooth. Then the Biodentine was applied into the cavity. Here, a space was left for the definitive restoration to be placed, and a bonding, adhesive, and then composite, and so on. So in this case, the whole treatment was done in one visit, and that's why the space was left here, which can be done. The other way of doing that is actually you can fill the whole cavity to the top, and then patient can come back after 2 weeks, and after which you can cut down, creating a space of 2 millimeters or 3 millimeters for the composite, and then you bond it. This depends on your preference, but also in some cases you want to defer the definitive restoration because you're not sure about the response of the pulp. You want to follow up, you want to see how the pulp will respond to the treatment. So the 2 weeks would be enough to have a proper evaluation, and then you decide if you want to proceed with the definitive restoration or you want to wait more. And this is just an example of bi-bulk fill procedure that was done on lower right second premolar. So you can see that there's a deep caries lesion reaching the pulp. Now, radiographically, you can see that it's very, very deep, and you would think that it is reaching the pulp. And that's exactly what I was saying, that sometimes you cannot predict which extent you will be excavating. But as long as you have one solution for all scenarios, then you don't have to really worry. Here, we ended up with a deep cavity very close to the pulp. You can see the shadow here, but that's why we decided to go for a bi-bulk fill procedure. We filled the whole cavity, and because of the close proximity to the pulp, we decided not to go for a definitive restoration. So the patient came back after 2 weeks. The pulp was assessed, everything was fine, and then the composite restoration was placed at that visit. In conclusion, preserving tooth structure and pulp vitality is crucial during deep caries management. And as we mentioned at the beginning, the caries management is not just to place a restoration, not just to restore function and aesthetic. It includes the preservation, protection, and prevention. Minimally invasive techniques and high quality hydraulic calcium silicate remain the standard of care in indirect pulp treatment, which should always be kept in mind. And most importantly, not all hydraulic calcium silicates are equivalent. Formulation matters, and that's your role always to look further and understand what's the composition. And there's, especially now, there's lots of products in the market which they are marketed as calcium silicates, but they barely contains any of these active ingredients. So it's always important to look about the composition, the formulation, and how this affect the properties. You may also want to test these materials. When it comes to Biodentine, the unique thing about Biodentine, it offers a combination of strength, sealing ability, remineralization potential, and pulp therapeutic effects. And those are the 4 properties that we want to have in any pulp capping material. It provides a cost-effective dual-purpose solution for pulp capping and dentine replacement. So unlike other pulp capping material, it is a restorative material. So you can still place it without the necessity of placing additional layer on top of it under composite. It is durable. Its durable seal makes Biodentine reliable, even in deep lesions with high risk exposure risk. And we explained how the interaction, the alkaline nature of these materials and their interaction with dentine contribute to this kind of seal that you want to have in your treatment. And lastly, with selective caries removal, Biodentine supports remineralization. So it gives a chance for caries affected dentine to be remineralized as part of minimally invasive approach. And by the way, you can also download the scientific summary that covers all these aspects about the use of Biodentine in direct pulp capping, which is a document that that's evidence supported for the role of Biodentine to suit its application as an indirect pulp capping material. So you can download this with the QR code that will show in the next slide after this. By that, I would like to thank you all for your attendance, and I hope that was useful and beneficial for you and for your practice in the future. Thank you so much.